Hello, this is Dr. Lorenzo Norris, Editor-in-Chief of MD Edge Psychiatry. Today we're privileged to have with us Dr. Hawk, who's going to be talking to us about physicians in mental illness and the structural barriers to disclosure. I'm going to encourage everybody to read the article that Dr. Hawk recently came out with, because in my humble opinion, it is very timely, it's very meaningful, and these are discussions that we need to be having. So please stay with us as we talk with Dr. Hawk about, if you will, the double stigma that physicians face and how we're going to start to work about our different ways we can think about to get through this so that physicians can get the help that they need. Dr. Hawk, welcome to the Psychcast.
Thank you so much, Dr. Norris. Really appreciate the chance to engage with you and your audience. I'm a psychiatrist and social scientist and philosopher, and I'm really interested in this topic. I have training in social sciences and bioethics, and I've done a lot of work on disability law and disability bioethics, as well as the culture of medicine and how medical culture can be dehumanizing. So I got interested in this question just to understand a little more deeply things that I've seen in my colleagues, in my patients, throughout my own training, feeling the stresses of just being a clinician. And I wanted to sort of bring some attention to the drastic under-disclosure amongst physicians who are struggling with disability in general, mental disability in particular, major depressive disorder as well.
So, Dr. Hawk, I got to tell you, I read this and I was so glad that our editor, Gina Henderson, recommended and thought, like, we need to have a Psychcast on this. Now we've talked about wellness, burnout, and depression on the Psychcast in different episodes at various times. Where we're at right now, particularly by the time this Psychcast drops, um, wherever you're at in the country, you're either, hopefully a good percentage of your population or your group is starting to, the physician group is vaccinated. You may have differing levels of vaccinations in your community. I want to say at the recording of this Psychcast, 20 million percent of the US population is vaccinated. With that being said, at this phase of the pandemic, people are even under more stress. They are tired, they are exhausted, and we know that mental health issues are going to start to come to the forefront. They already have, but we definitely know that. So I think that this is a very timely thing as we enter into this next phase of the pandemic and talking about physicians and how they can start to think about ways in which they can get help for themselves so that they can support their patients and their community. But Dr. Hawk, before we do that, you had a really interesting background. I mean, you had a lot of different things combined to help give a focus on this. Can you just tell us just a little bit about how you decided to combine all these different things to really start to look at, for lack of a better word, the culture of medicine?
Sure thing. Yeah, I'm somebody who kind of is a philosopher who wound up becoming a doctor. I
Mm,
kind of started in philosophy and theology. I went to divinity school, and I really started and kind of backed my way into medicine. I never really enjoyed medical school. I thought I even didn't do a residency at first. I went back and did training, did my PhD and other things. So then I came back to it because I miss taking care of patients. But I kind of used those experiences to inform some of the things I study, like uh, the culture of medicine and dehumanization, and how the way we construct our patients and ourselves can impact how we flourish or don't flourish, and how the kind of care we give our patients manifests. And I guess I try to just avoid any departmental labels and just look at a problem and see any kind of
mm.
tools that might be able to be brought to bear on the question.
Okay, well, that's what I'm talking about. So, Dr. Hawk, with that, now that we all have a little bit of understanding about Dr. Hawk's background, one of the things in your article that we talk about, I should say, you talk about, Dr. Hawk, is the challenges that physicians have when they are considering disclosing, if you will,
Mm-hmm.
that they have a disability. And maybe you could start to talk about what do you think needs to happen so that we can have a culture of medicine that would facilitate more disclosure by physicians that
Mm,
are suffering and that would actually qualify for a disability?
absolutely. And just for some of your listeners who may not know how bad the problem is, only about 1% of of medical students with a major depressive disorder will disclose it as a disability. So you can just think of that. These are people who go into medicine who are, if you look at your college class and remember it, these are the people who are incredibly resilient compared to the average college student. So amongst those people, only 1% will disclose their major depressive disorder. So in some ways, they're rational actors who are considering the culture and the institutions around them to not be conducive to the benefit of disclosure. They'll rather forego treatment and care and accommodations that are necessary, legal, and ethical, rather than face the consequences of doing that. And I think it's a big part of why there's high rates of depression and suicide amongst this population of people who are generally very conscientious, hardworking, resilient, emotionally regulated, just to even get to where they are. I can only imagine how bad it would be amongst the general population if we took a random sample. And I think it's something that's not often talked about, but it is great at getting more attention, because we have, of course, a duty to care for those who care for other people, but we also have an ethical obligation to our patients, to all the doctors that get lost, who don't enter the profession, who don't retain themselves in the profession, who don't use their good experiences of working through suffering to, share the understanding and empathy they might have with our patients. And the health of our physicians matter in a way. I remember once when I was in my training, I offered to do we had to do a research project, and I offered to test well-being interventions on the physicians, and it wasn't even approved as a necessary quality improvement program. And I thought, well, why is that not even considered worthy of quality improvements? That's kind of a cultural thing. And of course, the Therapeutic Alliance is all about being present and being there with your patient. But if we're not there, we can't give good care. So, and all of those factors really, I think, are necessary to this culture issue. But to answer your question more directly, I think there's a culture of ableism, the idea that if you're disabled in some way, you should leave the profession, that accommodations are sort of special treatment as opposed to equality in the playing field, that accessible education is not as rigorous in some way. There's also the idea that our default condition in our institutions, as well as in the culture at large, is invulnerability, imperturbability, as opposed to the human reality that our default condition is vulnerability. So if we build our institutions around the idea that we're all supposed to be invulnerable, you get a whole different set of problems. So I think that's a big part of the culture. The administrators tend to expect stoic struggle and linear lives, and the students tend to the students and us ourselves, we tend to have perfectionistic personalities. We equate moral worth with our professional progress. We think of help seeking as a weakness. By nature, clinicians are agreeable people. They're more interested in helping others than helping themselves. All these factors blend into this problem of the vulnerability, the construction of vulnerability in our culture. Then there's, I think, the ableism I mentioned. The third factor is the idea of becoming a doctor as a competitive enterprise as opposed to a cooperative enterprise, a shared enterprise that we have interdependence as opposed to independence about. And our fourth variable, I think, is our productivity tends to be valued more than our moral status and our moral behaviors towards each other. And I think those are the things that come to mind, but there's so many others.
There's so many others, and you gave us so much just to chew on there, so much to chew on there. Let's just kind of like unpack that a bit. I'm going to start with the idea of the invulnerability, because you do a masterful job in the article of really talking about from start at like just the admissions all the way through our training, all the way through fellowship, and I dare say particularly for those early career attendings, how this but we are, in certain ways, we recruit for a certain level of invulnerability. And why? Because saying you're invulnerable seems a little bit like kind of like, gosh, are these docs grandiose or whatever or something like that? But this is where I think it comes from. It's what you said, that stoicism. So that stoicism and being able to take or deal with whatever may come, or we like when people would applaud or clap for the doctors in the midst of the pandemic, and many of you might have been in institutions or places where hero's work here or something of that nature. It talks about that ability to serve regardless. As a matter of fact, we talk about in physicians the idea of it being selfless. But the other thing that
Mm,
you brought up, particularly in my role, people who are listeners of the Psychcast know that I'm also a dean in the School of Medicine.
mm,
So when you said silent competition, I just literally almost jumped up. I was like, that's it. Dr. Hawk has it. Silent competition, because no one's actually, at this day and age, I mean, in a lot of places, people aren't going to talk outright about the competition, but silent competition is absolutely, definitely just there and prevalent. And we just went through, for those who are not aware, the match. So again, whether or not you were thinking about competition or not, we have like flashpoints in medicine where silent competition definitely, definitely, definitely,
mm,
definitely
mhm, mhm,
comes out. And so you take all of that, and I wanted you to expand just a little bit more on this, because I personally
mhm,
find this quite a bit. The idea of when you, for physicians, the idea of being told that, or even considering the idea of taking a leave as just absolutely something that is going to make the problem potentially worse, depending on who you're speaking to.
absolutely, Dr. Norris. I think what you mentioned is really on point. We tend to think our moral worth is related to our professional status or
Mm,
competence. Where
yeah.
if you ask any one of us in training, hey, the guy who's making sure the floors are clean from pathogens, is he any different in moral status than you just because you have a doctor degree? And everyone would probably say no. But yet in our the way we conceive of ourselves as worthy,
Hmm.
and better, or less than good, it doesn't match up with what we would think about others. So I think that's definitely on point. And taking a leave is a very serious thing for a medical student or pre-medical student, or even a resident or attending. And often what happens is uh, administrators are a little more risk averse. So
Hmm.
it's a kind of like a first impulse sometimes when they see a problem. Sometimes inviting a leave, or requiring or requesting
Hmm.
a leave, depending on the spectrum of what is asked for. But the idea that sometimes disability is on a spectrum, and a necessary accommodation can often bring people back to some level of professional competence that might not necessitate a leave. Especially for the culture for on the student side or the trainee side is one of um, essentially, if you get off the path, there's something wrong with you and you're never going back. It's like irreversible failure. And so that's on the student side where that cultural piece needs to change. But um, you can easily improve functioning and prevent a leave sometimes. Yeah.
I think that is such a powerful idea, and I'm going to say it again. And it's even something that I need to start to think about. When someone comes to you and they're having a challenge, and particularly when you don't even know what it is one way or another, we need to start to think, um, let's not think leave first. Let's start to think about, wow, how insightful and aware of you to come and speak to us.
Mm,
What accommodations, or even
mm,
what resources, what things can we put around you to continue to allow you to achieve? If we, again, as long as with this stigma, if we consider those coming, asking for either support or even just verbalizing what they're going through as a sign of weakness as opposed to a sign of strength, that is going to be a problem. But instead, if we just start to look at it, and I'm saying that very like forcefully on purpose, even for myself, for my fellow deans or administrators out there, we need to not think leave first, because I personally think that that's going to be able to engender a lot of trust in our colleagues if we don't immediately jump to that. Clearly, if a leave is indicated, then a leave is indicated. But that, you have a range of options, and we should not just automatically jump to that. And we, something that you mentioned in regards to culture, we're going to get into this a little bit later in terms of admission and training, but it's so important. This culture of changing the culture, making it known that accommodations are available for you, making it know,
mhm.
making it first and foremost that everybody knows that no, our institution believes in this and that we have all of these things there for you. Because you're commenting a little bit about the accommodation aspect.
Absolutely. Before that, could I ask you a question about, like, as a
Sure.
dean, do you notice there's what do you think on the institutional side creates the incentive to have the administrators, all with the best of intentions, obviously, to kind of look more towards the leave aspect? Is it?
Well,
Something you've seen?
you know what, Dr. Hawk? Um, that's why I was so excited about your article. You
Yeah.
actually hit on many of the points. One,
Mm,
many institutions can be risk averse. All right, that's just the nature of medicine. Not so much risk averse, just strictly in regards to patients, but risk averse in something negative happening to their student or their resident. They don't they think that a leave frequently can be the best thing. It just a lot because of the rigors of it. When in reality, particularly if you go with our colleagues in undergraduate just education, they really know that taking a student out of their environment can actually be the worst thing for you.
mm,
So there's that the risk aversion, protecting the community, but also mainly
mm,
protecting the student or the resident, or the junior, or whichever stage in the career. The other thing is, in your article was very, I think, very, 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 very dead on, not dead, correct with this. We don't have the correct trained people set up to handle these situations.
mm,
So part of it can be a lack of knowledge and lack of comfort. You talked about that in regards to people wearing dual roles and doing different things. So
hmm.
there's more factors in that.
Yeah.
But those are two of the major ones. But all of that contributes to what you got at, which was the culture. And then that brings me right back to where we were at with the accommodations. Because if you don't
Hmm.
have people that are really devoted or expert in this, where there's a firewall, and then you don't have a culture where this is outright known in terms of the communication and the leadership, you're going to have some challenges. So can you tell us a little
Hmm.
bit about, like, again, just elaborate a bit on what you thought about the accommodations?
Yeah, yeah. Well, as you mentioned, so the person in the institution is called the disability service provider, or
Mhm.
that person is often um, under-resourced first because the institution may not be getting around to that financially. But if they do have somebody, it's often somebody who's for the whole university or just for the whole campus, like the whole medical campus, public health, basic science, medicine. But the problem is that this person, first of all, needs to really understand the unique issues that arise in a clerkship or in a residency, and the way medical curricula evaluate people and the way they organize their trainings. So, say I'm a student who has some issue that arises, and I go there and I say, look, this is what happened, and I'm seeking accommodations. They might say something like, okay, so what should we do? And the student might say, well, that's why I'm here to ask you something about this. Like, I don't really know
Mhm.
much about how your cardiology rotation works. So tell
You're-
me, like, what. So
Yeah.
the student will often wind up doing a research project on themselves just to get their own administrative help. So they'll, in addition to their studying and their clinical work, they're going to be emailing a bunch of people and getting forms signed. And there's, so the disability service provider needs to be specialized in medical education, and they also need to not have a conflict of interest in evaluating the student in other roles. I've heard a story of a student who's the person writing their dean's letter was also the one helping them get accommodations. So they didn't really want to tell them the whole story. Um, they don't want to tell them all the details and all the struggles that they really need help with. Of course, it's all well-meaning. It's just the structures of the way institutions are organized. So there needs to be trust and trust for confidentiality. There needs to be neutrality when it comes to the mediator role. And the third thing that often happens is that when a faculty member challenges the accommodation, they are a trained clinician. So their natural tendency whenever somebody tells them about a clinical problem is to say, all right, let's talk about the differential. Tell me
Mhm.
your symptoms. Tell me your
Right.
symptoms. Let's see if you really have this thing going on. And so then, of course, that's not their role. Their role is to say, okay, we got the letter from this person asking for accommodations, just like they would treat their patient when
Mhm.
they're writing a letter on their behalf. They would say, listen, you know that you don't have to tell your boss what's going on. You just have to tell them this is what is my necessary accommodation. But of course, we want to dig. So
Mhm.
so disability service provider is very important as a mediary, and I think that resonates for a lot of people who've been through the process and tried to get help.
Yeah.
From
No,
talking to people, I've heard that.
not only do I know it resonates, I think it's so powerful. So when we talk about changing that culture of disclosure, or that changing the culture to where people feel more comfortable with disclosing, is when I'm listening to you, Dr. Hawk, I think about those big main pillars, or there's many, but I think about one, how do we actually start to cut into many of these unwritten things that are discussed, whether it's the stoicism, the silent competition. How do we actually start to talk about that? The next thing that I start to think about that you just brought up is how do we actually, if you will, make sure that we are forefront and center in regards to accommodations exist, that we are known, and this is part of our institution framework. And then the other thing, which is structural. And by my last reading, 80% of everything you can do for wellness is structural. And what you just talked about was a structural, fundamental structural issue. Resourcing a disability service provider who can actually work with folks in a way in which there's not a conflict of interest, they are knowledgeable, and there's going to be the last word that you said, which I think is exceedingly important, which gets at the end of the day, students, residents, physicians, they need to trust their institution. And if you don't have the trust, that's the basis of any relationship. So I'm with you on that. Now,
yeah, absolutely. And the other thing you mentioned that I thought was great is that, you know, the trust and confidentiality is like double important when it's mental disability, in particular mental illness, because there's a double stigma. And over 80% of the disabilities that students register for are mental, neurological, psychiatric, psychological. So this is the main issue that disability service providers are going to face.
Okay. I agreed with all of that, and I'm going to highlight something that you said, and I'm going to give you credit for it every single time that I say it, because it just inspired me. We cannot have students do research projects on themselves. I'm taking that, man. We cannot have students do a research project on themselves to figure out how to get accommodations and what they need. We have to draw a line in the sand. I mean, I'd include residents, I'd include, if you will, physicians, attendings. Now, for listeners of the podcast, we are interdisciplinary. Although I'm speaking about physicians, I personally think that this could apply to any of my colleagues in the health professions. And I do want to say something before we move on to licensing board issues, that I was so glad that Dr. Hawk brought up this idea of moral worth. If the pandemic has taught us anything, it is that our health is in the hands of everybody. There is no, if you will, diva person or whatnot. All of us in a medical center work together, including our environmental staff, our social workers, our nurses, our PAs, our PTs, you name it, everybody. So I'm glad that you brought that up, because we don't talk about that enough. And I am a firm believer in that. But now, Dr. Hawk, the next part of your excellent article, when I was reading about it, you start to talk about, even, let's say everybody gets, we get past some of these outright institutional hurdles, all right, in terms of confidentiality, disclosure, and accommodations. Physicians still face challenges, if we're being honest, some questions in regards to licensing boards. Can you tell us a bit about that, sir?
Yeah, this is one of the things I found that was most surprising. So in general, our listeners can imagine that, they're in their school, they're in their training, they're early attending. And every year you get that email saying, would you like, you got to renew your license every 3 years or whatever it is. And if you look at the application, it's a little bit scary, because it's not just your name and address and do you love being a doctor. It's like, have you ever had this condition? Have you ever been treated for that condition? Are you currently doing this or that behavior? Are you able to speak? Are you competent and safe in your practice? So the good lawyer will slice through a lot of those questions and ask, are these violating the Americans with Disabilities Act or not? Some of them are directly relevant to the practice of medicine, and they're legal questions, like the ADA standard is that anything that's asked about, if it's a current or past diagnosis or current and past treatment, it has to directly affect their current functional abilities to practice medicine in a safe and competent manner. If it doesn't, if any questions are not about that standard, they're considered illegal. So just slicing things down that way, any question that just said, have you ever met with a psychiatrist? Have you ever been on medication for alcohol use disorder, cocaine use disorder, or anything like that? Or have you ever, have you ever anything that's not directly relevant to what's going on, would be considered a violation of the ADA. And then there was a study we cited from 2016 that showed empirically that they analyzed all 50 states licensing applications, and they found that about 2/3 violated the ADA. And not only that, what was really great about this paper was they showed that in the states that violated the ADA, the MDs in those states were also more likely to be not open to seeking care for a mental disorder specifically. So they found a way to connect the policy and structural gaps with the actual behavior of doctors, or attitudes, at least norms and attitudes.
When I read that part, and I look to the audience and listeners, I'll admit, I mean, I don't know if my memory was off or what, but when I read that 2/3, I literally had to, did I miss that? Was I not really comprehending that? Because that is a legitimate concern. And we're talking about this, and I'm focusing on this, not for physicians to not disclose because, oh, look, see what's out there. No, we're doing this so that we can be aware, because another point of your paper, Dr. Hawk, was that we need to start to advocate in to have these laws actually be enforced in all of the states. So, I mean, that's the reason to highlight it, so that when we speak about advocacy for physicians, that we are aware that this exists and that there are, like, this is not legal. So we need to start to have our advocates speak in a way so that we can actually address this. But again, the licensing board issue is relevant. And I think as if you are, again, I'll go put on my hat in terms of an advising dean, or if you're a residency director, or if you're a mentor, you have to be knowledgeable about that this exists. That should not stop you, though, in terms of, again, as you said before, going with a disability service provider or referring someone to one, or if you will, thinking about, okay, how are you going to address it? Because even though this is the case, you do not want to not disclose, but you do. I believe that, knowledge is power. You want to be you want to be aware of it so that you know how to work with it. But I have to, the licensing board issue was very, very big.
Yeah, I was just going to add to that a little bit and say, in some ways, what these clinicians or doctors are doing is very rational. They're saying to themselves, look, I know that these physician health programs and these licensing boards are basically, they're more punitive than therapeutic. They're not restorative. They're not looking at the person and saying, how can we bring this person back to functionality and health and integrate them back in? That's their intention, I believe, and they're good people. But generally, the person who has to go into this will, and there's studies on this that show this in detail, the costs of time and energy, getting a lawyer, getting many evaluations, the stress, the clinical appointments, all of that, and then the attitude of one having to defend themselves. Yes, I did say yes to this question, but now I'm like on the defense saying, wait, I have to prove that I'm competent and safely able to practice now, as opposed to this having and even though the board has asked me a question that's illegal, now the clinician is in a position of defending themselves. The other thing is that there's no oversight for the licensing boards or PHPs, so there's been some evidence of conflict of interest for some states, and there tends not to be as much parity in mental and physical health, and so that the way they're treated is often differently. So I believe many states have now had there's many legal cases out there that are going through the courts relating to this process. So hopefully things are going to improve, but I think everyone kind of knows it's a problem.
Right. Well, I should hope that it will, because if we go back to something that you said earlier, we have people in a place now where they have to search or figure out or do their own research project to figure out how they can get the accommodations that they need. And then now, even if you go through that, there could be a very real possibility that you also would have to kind of figure out how to defend yourself to prove that you're competent, even though that should not be in question because it's not currently affecting you. So again, I was being a bit shorthand with that. But if you start to add that up, to go back to the term that you use, and I liked it a lot, rational actors, this is what people face. This is if people are asking, why do people have such concerns in regards to disclosure and confidentiality? This is that reason. And when I speak with people across the learner continuum, from UME to GME to fellows to early career psychiatrists, all the way up to senior clinicians, everything that you just pointed out is right there. So Dr. Hawk, with that in mind, walk us through some of the things that, if you had your wish list, if you could, just kind of craft or blueprint it yourself, what would admissions and training right from the start look like in terms of for physicians and disability and accommodations?
Right. I would say the summary would be, let's treat our doctors just as we would treat our patients, with no less compassion and less generosity of spirit and openness, which means we would never advise our patients to just essentially sleep more and do more mindfulness to solve these kind of problems. We would look into the root causes, and we would find them interventions that were appropriate to their level of distress or dysfunction, and we would find a restorative approach to their lives. And in detail, that means when people are applying to school, we want to first be concerned not to lose people in the pipeline. There's been a lot of progress for people who are facing physical disabilities, needing accommodations and access to like wheelchairs and visual aids and things like that. But in terms of mental disability, it's still far behind. So in admissions, the first thing would be to have clear and inclusive and welcoming messaging to people, so that they know clearly that they're not going to be penalized for advising people. I remember even 10 years ago, one of my part-time jobs was helping people to kind of like as a pre-med advisor for college students. And people would often ask me, should I disclose this thing? Should I disclose this diagnosis? And back then, 10, 15 years ago, I would always say no. I would say, no, definitely don't do that. Because you know why? This whole profession is interested in helping people, but they're not interested in helping you. They want you to be the person who is an exception to all of the rules. So the first thing would be getting rid of the fear of being penalized. Number two, I guess, would be making sure that policies for disability access and accommodations and confidentiality are made known, so that people know when they're going through their training and their schooling that they can get help when they need it, and that these people who are struggling with disabilities are welcome. They're not just tolerated, but they're actually welcome and they're appreciated, because in our movements for social justice in medical schools, there's been great progress to increase opportunity and rectify disadvantaged and underrepresented groups. But disability has generally been not included in that as much as it probably should be. And so that's sort of like that kind of messaging and knowledge that like you're not just tolerated, but you're really welcome here. And we appreciate your experiences and unique way of being in the world. Contact information for your disability service provider should be available from the beginning. There shouldn't be, the policy should be public. People should know what to expect. Just like they should know how to get a dean's letter. Everybody knows how to get a dean's letter. Why doesn't everyone know how to contact their disability service provider and what will happen after they do? It's not that when you send an email, a bunch of people, in suits are going to come show up and ask you to go to a dark room. It's going to be, a normal process that's people are not going to overdo it or underdo it. It's going to be appropriate, necessary, careful, confidential. And clerkship requirements are often not announced in advance. So that needs to be improved also, because people who need accommodations don't even often know what they're going to need them for. They just show up to their clerkship, and then all of a sudden there's these things they have to do, and then they spend half the clerkship doing the research project on themselves, and then it's too late, because then 3 or 4 weeks go by and they say, what's the point? I didn't learn anything in this clerkship class, emailing people till 3 in the morning every night. So I guess that's a summary of training and admissions.
Yeah. Well, Dr. Hawk, you gave us, I thought every aspect of that I see incredible merit in. I'm looking forward to, and I encourage everybody on this one, look at the show notes, because Dr. Hawk just gave us like a very nice list of things that we want to consider, that we need to look at. And just what it was also, the other thing that it was making me think about is there's been a lot of talk in regards to burnout over the past decade. But a recent study, and others have been knowing this for a bit of time, is that when you look at physician burnout, but then you control or adjust for depression, you actually see that the depression, in a recent study, the depression was actually driving the suicide. So when I go back to your original point that, for instance, 1% of medical students with major depressive disorder disclose it as a disability, that's a problem. That we would, and what you just said, treat ourselves as we would our patients. We would not tell any patient to go in and not disclose something that could have a significant effect on your health. We just would not do that. So,
Mm-hmm.
Dr. Hawk, I really do feel as though you've given us so much information, so relevant. I'm not sure when this Psychcast is going to drop. It's one of those where I wouldn't mind having it drop twice for May Mental Health Awareness Month. So, but Dr. Hawk, I want to thank you for coming on the Psychcast. Any last words for our audience?
Yeah, absolutely. I would just say our faculty needs to normalize help seeking as well. It's if you're in a position where you're able to be a model to students, it should be normal to say, hey everyone, welcome to my clerkship. I'm leaving for my weekly clinician appointment, and you should too. And you should take your vacation, and you should we should also highlight success stories. This is this person had this horrible thing happen to them, and they made it through the institutional supports. And I think American culture is very individualistic and has a libertarian streak, and because of that, I think it gets human nature wrong. We are fundamentally interdependent and vulnerable. We're not fundamentally individual and invincible. So if you get human nature wrong, you're going to get dysfunctional cultures and institutions. And finally, I would just say for people who are in the trenches and struggling, take a look at the AAMC report on disability, 2018, I believe. And then for deans and faculty, get this as a part of your accreditation process. Make it be something that can be held with not just carrots, but also sticks. And the Federation of State Medical Boards has recommended these changes, but has not yet enforced them on these American Disabilities Act questions. So there need to be some enforcement for licensing applications. But we would also encourage the Department of Justice to issue guidance and ensure uniformity in practice. But ultimately, it's going to come from students and faculty and staff and people who get kind of eaten up in the process and have had enough.
Dr. Hawk, I want to thank you so very much for appearing on the Psychcast. I certainly would look forward to speaking with you again in the future. You share with us so many wonderful insights in regards to physicians and disabilities. I'd definitely be very curious to see what other insights that you have in regards to the culture of medicine in the future. Thank you so very much.
Thank you, Dr. Norris.